This talk is to outline the advantage of using a second circuit with a double lumen tube in thoracic surgery. The advantages are intuitive. Our circuit is very simple, it can be assembled from in any hospital with an ICU. We first start with a manual ventilation bag. Either a 1 liter bag or a 2 liter bag would work. We use a standard ventilator filter that we found in the OR to connect to our endotracheal tube connector in the double lumen tube. It has a sampling port to which we can attach oxygen tubing, and next we have an oxygen flow meter attached to our anesthesia ventilator, and we have connecting tubing to connect between the bag and the anesthesia filter and endotracheal tube between the bag and the filter. Finally, we have a snap which we place over a hole we've cut into the bag. This allows us to intermittently completely close or open our circuit. Here we see our circuit, the patient end. The left lung is being ventilated and the right lung is the surgical lung circuit connected. Here we place the bag on the table with the clamp on. Notice that we've removed one of the Y connectors in the heavy clamp. It's not necessary since we're going to start one lung ventilation from the very start of the surgery. It's just an extra weight distraction. Our first objective is to continuously monitor double lumen tube position from the time of initial placement until the end of surgery. Minor malposition, such as when the distal bronchial cuff begins to herniate in the carina, if easily detected, can easily be corrected. In contrast, inadvertent complete loss of lung isolation is at best a waste of time and frustration for the surgical team. If it happens at critical moments during the surgery, the result can be injury to the patient, potential severe, and even death. Once the patient is secure in the lateral position and correct confirmation of ideal position is confirmed with the bronchoscope, the double lumen tube can still move. It will tend to move only in an outward direction. Causes of this outward movement are ventilation pressure, surgical manipulation, weight of the circuit, swelling of the face and tongue, light anesthesia, and importantly, too much air in the distal cuff. As the distal cuff begins to herniate into the carina, if only the correct amount of air was placed in the cuff, a leak will occur around the cuff. Air under positive pressure will go around the cuff and exit the path of least resistance. In the common technique, it will exit to atmosphere where it is not easily detected. Too much air in the distal cuff is problematic. It will hinder leak detection, but it will also cause outward movement or avulsion or ratcheting outward of the double lumen tube. It can also hinder corrective action to push it back into place when we need to. We don't want to end up in this situation with the distal tip entirely to the trachea. It may be very difficult to correct if the surgery has been going on for an hour. Blood and secretions may have accumulated in the area. We need an action plan for that event, but this topic here today is how to prevent that from occurring in the first place. When we attach a second circuit, the air will still leak around the distal cuff. It will not affect the lung on the side of surgery, at least not initially. It will go through the path of least resistance out the lumen to that lung and begin to accumulate in our collection bag. This allows us early detection when the problem is simple to fix.
In this case, we are going to be operating on the right lung, and I have my bag attached. I attach my bag, there's no leak, the cuff is in the correct place. Now I'm going to show you how much air, I'm going to show myself creating a leak, and this is how we determine how much air to put into the distal cuff. I'm going to withdraw air slowly. Make sure I'm ventilating here. I'm going to withdraw air, and there you see the bag begins to inflate, there it stops inflating. So it's a minimum amount of air in that distal cuff we need. So I'm going to withdraw all the air just so we can see how much air we need in the distal cuff in this case. Okay, so there. In this man, this is a 39 tube. Air is still going in. Okay, we've stopped the leak. There's no more leak, as you can see. Now I'm going to empty the bag again, so I just want to show us something here. We see that the bag moves with ventilation. It's filling up and then collapsing. Filling up. Air is not accumulating in the bag. That's because what we're observing is we're observing the effective ventilation pushing air in and out of the lung that we are not ventilating. Now what I'm going to do is I'm going to gradually pull back on the tube until I create a leak again. There, we see now we got air accumulation there. We stopped. So now we can see I just created a herniation in the cuff. So this is a very useful monitor when we're positioning the patient to the lateral decubitus. All right, what do you think?
Yeah.
With the common technique, when positioning the patient will be on 2 lung ventilations. We don't do that. We leave the patient on 1 lung ventilation. We're not worried about low oxygen saturation. We have 100% oxygen to that lumen and can bag if we need to. While moving the patient, I'm monitoring for outward movement of the double lumen tube. Just like I showed you, I've got my hand on the tube. If I detect a leak coming from the bag, I can push it inward. I don't have to overflex the head, which can cause its own set of problems. This whole process may take 3 or 4 minutes before I have a chance to get down with a flexible bronchoscope to confirm correct position. With this technique, I'm confident that when I go down with that flexible bronchoscope, because I haven't overflexed the head and I haven't seen a leak, that double lumen tube is going to be very close to the position that I wanted it at the very position that's ideal position, so to speak. Yeah, there you have it. Because our circuit to the operative lung has been completely closed with the clamp, we may observe and often do a very small, slow leak around from around the bronchial cuff, which is insignificant. It can be mostly ignored. If we want to treat this leak or are very concerned, what we can do is before we put more air in that distal cuff, we should first check with a bronchoscope to confirm correct position. We shouldn't try and push the tube inward more before we check with the bronchoscope if we want to treat it. The other option is to create a slight leak in the bag so that the leak stops bothering us. Sometimes too much information can be a stressful thing. If we decide to inject more air in the cuff, we first go down with our flexible scope and make sure that the double lumen tube is in the correct position and that the leak is not caused by early herniation, which is unlikely with a very slow leak. When we confirm that this is the case, inject air perhaps 1/2 cc at a time, no more than 1 cc. This is a problem with a very sensitive monitor. Sometimes monitors are so sensitive that they can create a distraction and push us to doing things that we don't really want to do, like pushing the double lumen tube in too far or putting too much air in that distal cuff, both of which can be problematic. Our second objective is to allow us to better apply different oxygen concentrations to the 2 lungs, since we have different objectives. In the ventilated or dependent lung, we wish to use lower oxygen concentrations to help prevent against atelectatic or microtrauma. This is modern ventilatory strategy. In the non-ventilated lung, in contrast, we are trying to achieve a high oxygen concentration to facilitate effective lung collapse. More effective deflation of the lung helps protect against injury from surgical manipulation and facilitates better surgery. Commonly about 4 to 10 minutes prior to the surgeon entering the chest and creating a pneumothorax, the anesthesiologist will stop ventilation to the surgical lung and open that lung to room air or 21% oxygen. In our technique, we don't open to 21% oxygen, but we have 100% oxygen in the tubing. We will see in the following video clip movement of the lung that is associated with in response to the movement of the ventilated lung. We won't always see this, for example, in severe COPD or severe lung disease of any sort or pneumothorax, but this is useful information to bear in mind. So we will see that that lung is actually being ventilated before the chest is entered. In our case, we're ventilating with 100% oxygen. With the common technique, even if there was 100% oxygen in that lung beforehand, after 4 or 5 or even 10 minutes, the oxygen concentration in the lung we wish to deflate will be quite low. In chronic obstructive lung disease, air trapping in alveoli below closing volumes can inhibit deflation. On the bar graph, what we see represented on the y-axis is volume, on the x-axis is time. The blue represents oxygen, the blue represents nitrogen, the yellow represents oxygen. Over time, the alveoli where air is trapped will deflate in volume until the oxygen remaining in the alveolus will equal that of mixed venous oxygen, or about 15 volumes percent. On the right side of the bar graph, we are representing alveoli trapped, but with 100% oxygen in them. Over time, as the mixed venous blood absorbs oxygen from the alveolus, the oxygen concentrations remain high. This is why the denitrogenated lung will collapse more effectively, and also why we will see fewer instances of low oxygen saturations that are significant immediately following opening of the chest and collapse of the lung. The third objective is the only one really emphasized in prior suggestions of a second circuit, is the most intuitive. It will allow us to, a second circuit will allow us to achieve better control of lung reinflation for testing and recruitment without the need to adjust ventilator settings. It is simply a much more elegant and easy way to inflate and test the lungs, and we believe safer. In this clip, I'm showing how we can ventilate the patient without switching to manual mode. I simply open the oxygen flow. In this case, I'm going to show you a technique what I would use when the surgeon is asking me to test for leaks. I simply leave the snap on the bag so the circuit's closed, and I slowly adjust the bag till I receive the desired pressure. The pressure, when the wrinkles all come equally in the bag, tends to be around 15 centimeters of water. When those wrinkles disappear, it's about 20 centimeters of water. So when all the wrinkles are gone, the bag begins to expand. The pressure is about 25 to 30 centimeters of water. And of course, when the bag continues to expand to infinity, that's 40 centimeters of water. Here I'm using the alternative technique, which I usually do when I'm trying to flush nitrogen out of the lung, for example, while preparing for one lung ventilation. I just simply squeeze the bag, use my hand, and I'm probably reaching a peak pressure just looking at the bag there of about 25 centimeters of water. We have an option for connecting a separate pressure manometer, but we tend not to use it. It seems to be a distraction, but I'm not against it. Thank you for watching. I hope I've achieved the objectives that I started out with at the beginning. If you have any questions, I'd be more than pleased to get back to you and answer them. Your questions actually help me to make a better product. My email is at the bottom of this slide.